sense that there's something either ligamentously wrong, or maybe there's something actually wrong with the bone itself. Does that make sense? Like there could be a fracture, there could be an osteophytic overgrowth that causes some pain or some pinching or something like that. And typically when we're doing a physical exam, we want to start from least invasive to most invasive. Now, do you think it's least invasive to have them move their arm, or for you to move their arm for them? For you to move it, really, because if they move it, they have to activate their muscles, right? If you move it, they don't have to do anything. They're just kind of sitting there or standing there if you're moving them through that passive range of motion. If you take a patient through passive range of motion and everything looks really good, you then move on to the active range of motion. Before you do any of that, we inspect the area to make sure it's okay. Does that make sense? Have you guys ever had somebody, like, you tell them there's something wrong with your shoulder, like a chiropractic friend, they just like adjust your shoulder? They didn't look at your shoulder, did they? They just adjusted your shoulder. Is it possible there was a bruise under there? Is it possible you had a torn tendon? Yeah, there's some case reports I've seen where people have come in for a shoulder pain, chiropractors adjusting them, and then they have them take off the shirt, those things aren't getting any better, and the bicep tendon is completely separated from the arm. And so their problem was not that they needed to be adjusted, right? There was no point to do that. Unfortunately, you also leave yourself liable if you have a problem beyond what you did. Does that make sense? So again, you want to be able to inspect and see the tissue, then you go to the passive range of motion, and then active range of motion point. Doing those tests, after that, you can go to active resistant range of motion. Have you guys ever had a chiropractor ask you to hold your arm here and they do some sort of a test? That's a muscle testing as we use it to evaluate a patient's spine or joint. That's not the same thing as doing an active resistant muscle test. Okay, an active resistant muscle test is trying to test for the integrity or the health of that muscle itself. So what we do is we start off with inspection. And I would know this, we're going to start off with inspection. We usually look at an area that maybe has a problem with the joint itself. We compare it to the other side. We always want to compare side to side so we know what's normal for that patient. Not everyone's normal, right? So maybe they have overall decreased range of motion. We then move into the passive range of motion, active range of motion, and then we do active resistive range of motion. Okay? Those last three parts are known as O'Donoghue's test. An O'Donoghue's test can be done on any joint in the body that has a degree associated with it, being like this is 180 degrees of range of motion. We normally don't qualify some other motions like this, just elevation of the scapula, so we don't always qualify all those degrees. So we always want to start off with a visual inspection. Now this is taken for granted that we've done a case history. So we started off with a visual inspection. Bless you.
Thank you so
We normally
much.
will move into palpation, touching the tissue to make sure it's okay. We'll palpate the bony landmarks to see specifically if there's anything associated with it.
Thank you,
Then we'll
amen.
move into a passive evaluation if we're looking at the musculoskeletal system. It may be different if we're looking at the lungs or evaluating the heart or some gastrointestinal issues. After we do the passive range of motion, we'll have the patient and then we'll have them lastly do active resistive range of motion. So let's learn how to do the first part of that just for the glenohumeral joint. Okay, so the motions of the glenohumeral joint are all the motions or all the ranges of motion that we can see. Bless you. I know there's a lot of pollen and dust and stuff. So what we're going to do is I'm going to have you stand up with me. We're going to go through and make the motions together. And then I'm going to have you evaluate each other to see whether or not you can find it.
You read them pretty well.
So the first thing we're going to do is abduction. If I ask you to abduct your glenohumeral joint, you're just going to do this. Abduction is here. It should be about 180 degrees. So they're going to have you come into adduction. Adduction actually crosses across the chest. If we're dealing with someone who has a very large chest, we just have them lean a little forward so that we can see the full glenohumeral joint motion. We're then going to come here and go into forward flexion, which again should be about 180 degrees. We're going to take our arms back into extension here, somewhere around 70 degrees. We're then going to bring our arms up into this neutral position and move them into external rotation. Go back to neutral, and then see internal rotation. There we're going to relax. Now our glenohumeral joint is associated with the scapula, so we typically will evaluate the scapula with it as well. So can I have you bring your shoulders up to your ears? Can I have you roll your shoulders forward for me? And then can I have you roll your shoulders back? Okay. Now, just by doing those motions, you should be able to notice whether or not your patient has an imbalance between left or right. You don't have a clue what's causing it yet, though, right? Now, is this the first part of the exam you would have done if you were taking care of a patient today? No, because the first thing you would have done was what? You would have visually inspected the tissue. The second thing you would have done, touch, palpate, okay? The third thing you would do is you would do the moving. So you would literally take your patient's arm and you would move them through those ranges of motion to evaluate for ligamentous stability. If all that checks out, then we would move into this active range of motion. And then lastly, we would do active resistive range of motion. So what I'd like you to do is pair up. You can do 3, 4 people if you want to. And I'd like you to put each other through this range of motion and see if you got anyone or if you can detect anyone who might have a limit in that range of motion. Okay? There might be a limit back here. Maybe a limit. Well, then come back together. I don't know if you have to go through it. Look at the example. Okay, so let's do that. We'll spend the next maybe 5-ish minutes doing that. Yeah, for the window here we'll do it. So the same thing we did. Just all right, see if they find any dysfunction.
So, we're going to start going up with the arms. All right, and back down. Don't let your chesticle get in the way. All right. Now, what do you do next? Yeah, that one. Right. There we go. You seem to be no range of motion so far. All right, let's go to the top. And down to the bottom, 70 degrees backwards. Can you not do that?
Yes, I can.
I was going to say that. All right, so what else did we do? Get your jacket. Good. What are you doing?
Jacket. I'm fixing my shirt.
Sure.
It's hot right now.
That's because you got a jacket.
Yeah.
I'm not kidding. Anyway, yeah, no, I see no problem with your range of motion. How's my range of motion?
Me neither.
You gotta keep flexibility.
Do this, but bring it. There's a little bit of range of motion there.
Yeah.
I think you cannot go open your chest as much.
I get it. Because I can feel my back pressing against this.
Yeah, now it's better.
I have to push my shoulders much further back because I'm still like that.
So there it is.
Yeah.
Then here.
Here.
But
Oh,
shirt
I
backward,
push
I
on back.
think.
All right.
This one is not. We did it.
Full range of motion. We love to see it.
Well, you have a little bit of.
All those push-ups I do.
You need to open your chest. Some
You know what?
photograph process will
How does one do this? Is there an adjustment for that?
probably.
You know what? Out there, you're probably right.
You can do it yourself. You don't need, just in the floor when you're doing push-ups.
Just
After
hold.
you're doing your practice push-ups, just expand your shoulders.
Cobra, yeah. What are we doing? Are we doing?
That makes a little more sense. On the external wise, you're able to go back. But then here you're looking at this, not on there. Let's work together. Let's work. Let's go ahead. Get me right.
Is it like almost set?
Is that a shirtless sleeve? Okay. It's a very new concept. I've seen sleeveless shirts, but not shirtless sleeves.
Yeah, baby, we all
That's what it means. Here's where you get the.
I feel like my arms always do. Like if I have my arms covered up,
Especially when you're asleep like me, but I hate it. I hate to wear so much clothes.
It's a hot place, right?
Yeah, I used to be naked and
like I'm too protected. Yeah.
I once got frosted feet.
Oh gosh.
And now I have very little grip strength in my feet.
Snip.
No, that's what's referred to.
I know. It's just so cute.
It didn't bite me, but it got me a little bit.
Technically, we're supposed to.
I lost fingers, both fingers for one, and now I got very little grip.
Honestly, mine looks like
oh, they check me quickly.
How's your range of motion? How's your
Good. She's extra flexible, extra flexible, just the shoulders. What about you?
Everything's good except I need to push my
But also we
shoulders back a little bit.
He needs to open his heart, his chest.
So open my heart and choke my chest.
Yes, exactly.
Yes.
Legs.
If that's the case.
I don't know.
So let's go back again. So, with the people that you're working with, you may have noticed that there's an imbalance between right and left. Oh, was there an imbalance?
Anytime we find an imbalance for someone who's not really soliciting like our advice, one of the follow-up questions would be, what do you think would be a good thing to ask them as a follow-up? What was that? Have you had any previous injuries before? Absolutely.
What's your daily activity?
Daily activities, activities of daily living, we call those ADLs.
You haven't started that for me.
What was that?
Push-ups.
Someone say something else? Pain. When someone's not really soliciting your advice and you're having them go through a range of motion and one's just like not where it's supposed to be, maybe they just don't want to do it. Maybe they didn't come to class thinking I want to talk today. They came to class thinking I'm barely hanging on and I just want to chill in the back. Okay, so stop making me do stuff. So one of the follow-up questions anytime you have something like that, you have anything associated with that. In your office, you're probably already going to have a pretty good idea whether or not your patient has pain or discomfort in the area that you're examining. So if they came in for a shoulder injury, you already know that there's obviously pain or discomfort. So instead of asking them about whether they have pain, what are we going to do? We're going to rate the pain. So, Mrs. Smith, I understand a couple weeks ago you had this shoulder injury. How would you rate that pain on a scale of 0 to 10, 10 being the worst pain you've ever felt in your life, 0 being absolutely no pain, when that first happened? Mrs. Smith may say, when this first happened, it was a 6 out of 10. How do you feel today when you came into the office? Where are you at right now? She may tell me, it's a 9 out of 10. I think it'll work today. That's why I came here today, because I've got to get this checked out. I kept hoping it was going to get better, but it didn't. So the next question I'm going to ask is, what's it on average? Normally it's somewhere around a 6 or 7. It's kind of stated in that area, but today it's got really, really bad to the point that I can't even lift my arm. And now I know it's a 9 out of 10, and that is pretty severe. The other thing too is I also know the progression of her illness. Does that make sense? Like I know that this is progressively getting worse over a 2-week period. Okay? So all of that information would be follow-up questions I would ask. I wouldn't necessarily ask her if she has pain, but I would ask her before I began the examination to point to where she feels pain. Because remember, for some people this is their shoulder joint, for some people their shoulder joint's up here, for some people their shoulder joint's their scapula. So again, you want to make sure that you have clear understanding about what you're looking at. What we're looking at right through here is your clinical sciences lab manual that you guys will be going through as you get into the clinical portion of the program. We're usually going through doing these evaluations on each other. Part of the skill is demonstrating that you understand the baseline normal measurements that we would see associated with these. So forward flexion is typically 80 degrees, extension is 60 degrees, external and internal rotation, external is typically 90, internal 70 degrees. You'll notice associated with scapular retraction, protraction, and elevation, there's no degrees associated with it. We really are just looking for imbalances. And these people typically have a slight discrepancy from side to side. Yeah, typically like if you're right-handed or left-handed, you might have just a small amount, like maybe a centimeter of elevation on that side. Okay, but it shouldn't be like 2 to 3 centimeters, about 3 fingers width. There shouldn't be this big of a difference between my right trapezius and my left trapezius. Does that make sense? So there shouldn't be that big of a difference. Active range of motion is that. Active resisted range of motion is something that's different, okay? When you get to the clinical skill class, you're learning how to do orthopedic exams. One part of the active resistance test will be associated with the test that's mentioned, the Donahue test, and that gives you good information about the integrity of the muscle. The muscle strength is scaled, or rather it's weighed on a scale of 0 to 5. If a muscle is able to extend out, or go into joint position and go against gravity, this is a 3. Okay? If that patient can then receive some force into that and still maintain that joint position, but it kind of gives out, that's a 4. If they can hold it there against resistance and it stays there, we would call that a 5. Anywhere between a 3, 4, or 5, we're pretty good at taking care of in our office. Okay, if it's a 3, a 4, or a 5 muscle grade, then we feel pretty good, confident taking care of that. Now, if the patient's going to move their arm and they can't even get it up against gravity, we would grade that at a 2, and now we're getting a little concerned. Okay, our major concern is that the nervous system controlling that muscle may have a problem. Bless you. And with nervous tissue, the longer we wait to treat it, the worse it gets. And we may even lose the overall functioning of those nerves. So we want to be very careful. Could we still take care of somebody with a muscle grade 2? Yeah, we still can take care of patients like that. We just want to be a little more careful, and we want to do more frequent re-examinations to make sure we're trending towards improvement instead of getting worse. Okay? A 1, they can barely lift it, or 0, there's no motion at the arm whatsoever. Typically, we see that in something like a dislocation, maybe a severe fracture or something like that. Someone in that position may be coming to your arm, right, cradling their arm, and you can visibly see the shoulder is actually kind of dislocated. So again, we not only are going to test the muscles to see whether or not there's stability and support there, we also will grade essentially on that 1 to 5. Okay, so a 1 to 5 scale. Does that make sense? We're very confident taking care of the 3, the 4, and the 5. The 7 and 3, we want to do maybe more frequent reevaluations, but we typically are going to see some pretty good progression with those. Now, how do you do an active resisted range of motion test? It's pretty straightforward. We just want to put one hand above the joint, one hand below the joint, and then have the patient hold that joint position as I try to apply a little bit of pressure. Now, you'll notice I'm saying apply a little bit of pressure. I'm not trying to beat them. If a person puts their arm here, I'm not like trying to be like, and try to like overpower them to prove my manliness. Okay? It really is just can they hold the joint position. So the amount of force you use is going to be relevant to the person you're testing. Does that make sense? So if you were testing like a big power lifter, you might have to use a little more force. But for your average person, you don't really have to do that much. Can I have somebody come up here and I can show you real quick just an example of abduction and how you would do an active resistance test? Come up. I appreciate that. Thank you. So what I'm going to have you do for me, now ordinarily I have them see you do this. What I'm going to have you do for me is just turn your face there, just so they can see you. I'm going to have you take your arm. Now listen, even though I've had him volunteer, I still want to ask, do you have any shoulder problems or any kind of pain with discomfort in the shoulder? Just to make sure, because sometimes when you're working on your classmates, they just got that little bit CrossFit 10,000, and they did like 1 million like presses over the weekend, and they can't even move their arm, but you can't tell because they do it all the time. So you always want to still ask, has anything happened? Are you okay? Do you have any pain or discomfort or anything like that? And then typically before you touch someone without it being in a physical exam setting, you want to ask permission. Like, is it okay if I touch you? Is that okay? And I can just take your arm for me and just hold it out to the side. And what I'm going to do is I'm going to take one hand above the joint, because the joint's the glenohumeral joint, right? And then I'm going to put one hand close to the joint and just below it. So I'm just underneath this deltoid muscle. So it would be the exact same thing if I were going to evaluate this bicep. And if you bring your arms to your side and just do this for me, I'd have one hand here at the elbow, back here at the elbow, just above the joint. I put one hand just below the joint, as close as I can to the joint, and then I just would apply slowly, gradually increasing in pressure, okay, force, as I did that. Okay, so again, whatever joint you're evaluating, it's one hand above, one hand below. Let me have you bring your arm back up for me. Okay, so now I'm just going to put my hand here, I'm going to put my other hand here, and I'm just going to apply a force now. Try not to let me move you, okay? Hold. Again, this isn't a wrestling match. I'm not trying to overpower you, but I can tell that this joint is locked. I'm going to hold that for about 3 to 5 seconds. 3 to 5 seconds is a long time. Relax for me. When you're doing a time test. When you guys get to your time test, the clock is going, and you're trying to hold that for 3 to 5 seconds, it's gonna feel like it's 20 seconds. And then you're gonna lose, and you're gonna fail, and you're just gonna have to retake the class and drop out of the program. I know, it can't, it like it snowballs really quick. But if you don't hold that for 3 to 5 seconds, the muscles don't have time to either activate completely or begin to fatigue. Sometimes muscles are okay when we first start, but about the 2-second mark, it begins to just drop down. So we may have some delayed muscle weakness where the first second or two it's strong, and then in 3 seconds it just kind of collapses, and that lets me know that there's something wrong with the muscle tissue itself. So we gotta hold it for that time. Is that easy to do? Yeah, it's super easy to do. The information you get from it is really valuable. Thank you for doing that for me. I appreciate that. Now, if you get into your clinical practice, you guys are doing those things to each other. Before you do that, sorry, my laptop checked out on us. Before you do anything like that, you're also going to be doing these things right through here, which is bony palpation of the joint or the associated tissue with that joint that's somehow directly or indirectly connected to it. So this quarter, as we're going through and we're learning all these bones, we're not learning these bones just to pass a test. We're learning these bones because every single day in your office, you will be touching patients at these positions, and you will be evaluating for whether or not that tissue is sound or not, and whether or not it's stable or doesn't. If you don't know what healthy tissue feels like versus pathological tissue, you may adjust someone that has a fracture. You did also cause that tissue maybe to cut something else internally that's called bleeding. You could fracture a rib, and that rib could puncture a lung, and then you have a collapsed lung as a result of you not doing a full evaluation of the tissue. So again, as we go through and we're learning what these sternocleidomastoid articulation and clavicle and all these different structures that are associated, I don't want you to think that I'm just doing this as we need to, or just because we need to pass our DBC test. It's because every single day you will use this information. Okay? So again, what was the name of that test that we could do? Where we evaluate passive range of motion, active range of motion, and then active resistance. Start with an O. Donahue Hughes. O. Donahue Hughes test. That's the name of that test. And again, you could use that on any joint in the body. Now, when you get to this class too, you guys will also be doing your musculoskeletal evaluation. And then you guys will go into the fun stuff of doing all these different special tests that are associated with evaluating those joints themselves. So let's talk about how to classify joints, and let's get into that. Because I know you've been just chomping at the bit to get to it, excited, fired up now. So when we look at joint classification, and today we're going to specifically be talking about the relationship to the skull. It's no different for any other part of your body. Okay? So again, the classification we're talking about with your skull is the exact same thing combined with any other part of your body. We classify our joints in 2 different ways. We can classify it based on the material that that joint is composed of. And then we can also classify it based on its functional use, meaning what way does it move, how does it move, how much mobility is there, or is there no mobility there. One thing that tends to be true is that joints that have greater range of motion tend to be more susceptible to injury. So if we look at people and their shoulder joints, most people at some point in their life are going to have a shoulder injury. Okay, so most people, because of the mobility and the range of motion of the shoulder, it's going to lend itself to some sort of injury at some point in their life. Now, as a chiropractor, will your patients tell you that they have a shoulder injury? It kind of depends on how you set yourself up. If you set yourself up to only be spinal specific and you don't do anything outside of the spine, there's a good chance they're not going to tell you about anything apart from the spine. Even that they may not tell you. But if on your physical evaluation, you also go through and you just do a quick range of motion of the extremities, you do a quick palpation of the extremities, the patient may even ask you, like, hey, I've never had a chiropractor go through and evaluate my arms and legs before. Why are you doing that? Like, oh, okay, well, when we graduate, we're actually very qualified to take care of every joint in the body itself and use a holistic patient. So I'm just going through to see whether or not there's any glenohumeral joint or elbow issues or hand issues that may be contributed to some sort of spinal issue, or maybe the spinal causing the problem at that point of dysfunction. So yeah, actually, we're very qualified. I've helped a lot of people with knees, foot, ankles, all kinds of things. Now, that patient, when they have a foot injury, what are they going to come do? They're going to tell you they have a foot injury. Okay, so again, it's really about how you set yourself up. If you set yourself up to be a purely spinal doctor, there's absolutely nothing wrong with that. Okay, if that's how you want to practice, that's fine. But remember, you're obligated to take care of patients' entire life. So if they come in with a foot injury, you should be able to somehow detect maybe their gait's off a little bit, and you should probe a little bit and try to get them to the person that can help them if you're choosing not to help them. Does that make sense? So the joint classifications, again, classified by the material. There's three types when we talk about the material. There's a fibrous joint. A fibrous joint is typically an immovable joint. The best example you can think of is probably your teeth. Do you want your teeth moving around? Anybody have a dream where your teeth fell out? Okay. It's freaky, right? You gotta take the bias of it, or you're brushing your teeth, and you just smiling, and all your teeth start to fall out. Your dream, pretty creepy. I don't know what that means. Okay. Some of you dream people, you can tell me what that means a little bit later. But that's a good example of a fibrous type joint. It's classified as what we call a gombosis. I remember those in the gums, gombosis. So again, a fibrous joint is immovable or partially movable joint, such as sutures in the skull. Now, is there a lot of motion in the sutures of the skull? You know what I mean? Like, we can't just move our temporal bone or something like that. But there is some slight motion, depending on the actual depth of the connection between the fibro cartilage and in between those two, or the fibrous tissue. Cartilaginous means that this is a partially movable joint. When we think of cartilaginous, for us, probably the most frequent place to point is the intervertebral disc. In between each one of your vertebrae, that is a joint. Okay, so we don't traditionally sometimes maybe initially think of those as joints, but those are joints in between the two vertebral bodies. It's classified as a cartilaginous structure. And typically it's partially movable. Okay. And then we see some problems. It's partially movable, but this is partially movable. Wait, what? They're both partially movable. So which one's which? You have to kind of know which one falls under which category based on the tissue type you're talking about. So on the test, I asked you to classify the joint of an intervertebral disc. So you have to know that that falls under a cartilaginous type joint. If I asked you to classify a cranial suture, you would have to know that goes under a fibrous type joint. Now we'll go through and we'll look at the different classifications of each one of those and where they fall. You need to know the difference beyond that because these words are very confusing. Okay, because they both say partially movable in there. The key normally, if you're trying to do a definition, if something is fibrous, it should have this in there somewhere. Immovable or partially movable. So it should include the immovable portion. A synovial joint is what we think of when we think of the glenohumeral joint, our elbow joint, our hands. Those types of joints are freely movable. It doesn't mean that they can all move in the different ranges of motion. It just means that they have at least one degree of motion that they can move in. Like my hinge joint here at the elbow, this is flexion and extension primarily. That's basically all it does. And then at the forearm, we can also do pronation and supination. Okay? So again, the joint doesn't, when we say freely movable, it doesn't necessarily mean that it's got all degrees of motion. It just means that it can move at least within 1 degree, okay, or in one range. The functional classification is based as synarthrosis, synchondrosis, and I would also write in there amphiarthrosis. Amphiarthrosis is A-M-P-H, amphi, A-M-P-H-I, and then arthrosis, amphiarthrosis. Amphiarthrosis is just another way of saying synchondrosis. Okay, so synchondrosis and amphiarthrosis are the same thing, or AKAs of each other. Now, a synchondrosis permits slight mobility. Again, we think of these as being similar to a cartilaginous joint, where they follow. And what does chondro mean? It means cartilage. So it falls under the category of a cartilaginous type joint. So synchondrosis permits slight mobility. A diarthrotic joint is freely movable, which sounds like what other category we just talked about? Synovial. The synovial. So all diarthrotic joints are synovial joints. And we're going to see that synovial joints have 6 classifications associated with them. Okay. You see why this can be a little confusing? Yeah, it can be a little confusing because unfortunately there's some overlap between them. And then we can classify the functional and structural and put them together at the same time and look at it from that point of view. We'll also see that some things will be a fibrous type joint, but technically it moves like an amphiarthrosis. So even though the tissue type, which is what that first classification is based on, may be fibrous, it actually movement-wise is classified as something else. One way I remember this for functional use is the word SAD. That's why I said we need to write the amphiarthrosis here. SAD would be synarthrosis, amphiarthrosis, and then diarthrosis. And remember, amphiarthrosis is the same thing as chondrosis. Some people remember the phrase sadism. Let me show you how you write it. Yeah, I know the creepy stuff like stays with us. S-A-D, and then you go below it. I-S-M, sadism. So synarthrotic is immovable. Amphiarthrotic is slightly movable. And diarthrotic is freely movable. So just that little phrase right through there sometimes helps people connect those dots. Remember when you go to take your test, you guys, like your national board test, you guys will be taking a test that's covering essentially 6 terms of material, 5 to 6 terms of material. There's no way you can remember all that. But you can remember like little sayings and things that kind of jar your memory to help you get where you need to be. Can you say what this SAT is? Yeah, so S means synarthrosis, and it's connected to an immovable joint. A is the amphiarthrosis, which is an AKA for synchondrosis, but for the purpose of the phrase, that works better as the amphiarthrosis, and it's slightly movable. And then the diarthrosis is freely movable. Now, some of that stuff you're going to hear, like these little things to remember, you're going to be like, that doesn't help me at all. And then for some of you guys, it'll be like gold. For me, it was like gold. I could use those if it really helped me out a lot. So let's talk about different categories of fibrous joints. Really just 3 of them. If something's a cranial suture, it falls under the category of the fibrous joint because of the tissue that's holding it together. Now remember, some cranial sutures can be slightly movable. Anybody here have any of those cranial sutures adjusted? Yeah, and if you do anything like the TRT, you guys will adjust the sphenoid bone, right? You guys adjust the sphenoid bone. You also heard about sacral work, sutural work as well too. So again, there is some motion that's happening there. It's just not as much motion as we see in amphiarthrosis. A syndesmosis. A syndesmosis is essentially where the joints and the bones are connected by a band of connective tissue. The easiest example I can think of that is between your ulna and your radius. Between your ulna and your radius is a band of tissue. It almost looks like just a sheet of fibrotic tissue that's holding those 2 bones together so they don't just drift apart. So again, we'll see that in just a minute, but that's an example of a syndesmosis. Now, there's more than one syndesmosis in the body, but really that's the easiest example I can think of, but we do need to be familiar with the others. In the gomphosis, we said that was where? The teeth, right? And can you move your teeth?
I hope not.
Can you move them if you get braces? Yeah, and it's slow and it takes a long time, and the longer, the older you are, the longer it'll take. I had braces when I was in my 20s, and it took like 5 years to get my teeth. My teeth were really bad, but it still took like 5 years. And when my kids got braces, it took them like 18 months, 12 months to get this stuff moved. So the longer the bones are kind of set, the longer it's going to take to get things back. That's also helpful to understand when it comes to adjusting patients, especially if you're trying to use spinal curves. That's sort of your measurement of improvement. Because if someone's 45 years old, it's going to take a long time to get those curves where they need to be if they've been dysfunctional maybe for the last decade. Does that make sense? And when you explain that to your patients, a lot of times that helps connect those dots. Now, these are all types of fibrous joints. We want to know that sutures, syndesmosis, and gomphosis are all classified as a fibrous joint. A cartilaginous joint is a synchondrosis or a symphysis. When we hear symphysis, we're thinking pubic symphysis normally, but a symphysis type joint is also what we find in the vertebra. So that disc that you see in between the vertebra, that also is a symphysis type joint. Okay. A synchondrosis is what we find joined by hyoid cartilage. It's typically what we find in the epiphyseal plates where we have our open growth plates and the bone is still growing in length. That's what closes off as we mature. Synovial joints have some things in common. Yes, ma'am?
Do synchondroses occur in adults?
I'm sorry, say that again?
Do synchondroses occur in adults?
Well, if we look back here, like with our synchondrosis permits slight mobility, and we see them there in the vertebra and the cranial sutures, technically they fall into that same category as sort of a symphysis. Yeah, so they fall kind of in that same category. So when you think of symphysis, you could think of synchondrosis, you could think of those two as being very, very closely related to each other. A synovial joint is diarthrotic. So all synovial joints are diarthrotic, okay? And remember, diarthrosis means that it's freely movable. All synovial joints have things in common, whether or not they have like this much motion and this motion right here. You know what this is called? I'm doing flexion, I'm doing extension, abduction, I'm doing all of those motions of the shoulder together. It's circumduction. So when you see this motion, it looks like I'm drawing a circle, right? Circumduction is a combination of all those motions we saw earlier. Okay? Circumduction is a combination of all those motions we saw earlier. So whether you have that much motion, where you're literally just talking about flexing and extending like one of your fingers, all of these joints are going to have the same things in common. So they're going to have space in between the two bones, and that space is going to be filled with synovial fluid. That fluid is essentially lubricating the joint and helps reduce friction in that area. Yes, sir?
So when we're doing like a food examination,
Uh-huh.
should we add circumvention to that as well?
You could add it if you want to see more of a functional examination. Typically, when you're doing like an orthopedic type test, you're trying to see it in that individual range of motion to see what the issue is. Could you couple that with a functional motion like that? Yeah, absolutely. Especially if you're taking care of athletes, because it may not, their decreased range of motion may not show up until they go into circumduction. But that more likely would be associated with some sort of a muscular type injury. It still would help you identify because that range of motion that's limited, typically to the muscle associated with it. But so you can still get good information from it, but it would be evaluating purely the joint at that point. So when you see the individual ranges of motion, they're specifically designed to evaluate the joint. Circumduction is more like a functional evaluation, which I would say too. It's like having someone do an overhead squat or something like that, and actually go through the range of motion, activating the muscle tissue, looking for imbalances. Synovial fluid, again, it lubricates the joint. The ends of the bones themselves are lined with hyaline cartilage, and we said all hyaline cartilage is what kind of cartilage? All hyaline cartilage is articular cartilage. Remember, don't be afraid to be wrong. Okay, if something like pops in your head, just say it. If you say the wrong answer, it's okay. When you say the wrong answer in public, you activate a portion of your brain called the limbic system, which makes you feel a little embarrassed. When you feel embarrassed, your brain actually will log that information, put it in the correct path so that that doesn't happen to you again. So every time you're wrong in public, you actually are helping yourself into a test. Okay? So again, when you're wrong in front of your peers, at least if you care about what your peers think about you, it'll activate that embarrassment center, and it'll essentially make it easier for you to remember. Now, synovial fluid is also important to us because what happens with that synovial fluid? What builds up in the synovium? Those gas bubbles, right? The cavitations, the crack. I used to think it'd be cool to have like a big chiropractic board that said, got crack. You know, but I was like, no, that's too far. You can't do that. I probably wouldn't be allowed to be a chiropractor. I'd probably lose my license and stuff. I'd probably get arrested, I'd imagine, for people who misunderstood it, right? So whether you call it a crack, whether you call it cavitation, some people are really passionate about what you call that. It really is just gas bubbles that are formed inside the synovial membrane. You release those, and they will stop. Okay? Does that sound a good thing or a bad thing? I don't know. I mean, is it bad? Is it good? I don't know. Is that sound indicative of a good adjustment? No, not at all. It doesn't necessarily do anything to actually indicate that that was a good adjustment, which is really sad. You guys like that sound? I love that sound. You just hear it. I love the videos. They're like, you're like, ooh, put that on replay, listen to it again. It's nice. You know what I mean? But unfortunately, it has absolutely nothing to do with whether or not you actually move the segment you're supposed to. If you were to get adjusted by a physical therapist, they would call it manipulation. Typically, they would call it a gross manipulation. They might take your leg, put it across your body, and then you start lifting it as you rotate, and your spine would just go all the way down it. The problem in that situation is that when you apply a general force and everything is just cavitating, and you really may be moving the segment that's truly subluxated. No, normally the thing that's a primary subluxation won't move without a direct force being applied to it. It might, you might free it up, but a lot of times it won't. So what's all that sound coming from? The joints above, the joints below, and now you're making all those joints hypermobile. Is that going to help your patient, or is it going to make things worse? It's going to make it worse. Well, what you didn't actually address the dysfunction. You missed the segment, and you didn't actually bring any kind of ability or range of motion or stimulation, even neurological stimulation, specifically to that joint. It's still stuck, and now you increase the range of motion. When I was very early in practice, I adjusted somebody in a side posture, and it was like everything flipped. And unfortunately, their back went into like a spasm, and it was too much for them. It was overstimulated. And I learned that by adjusting too many segments at the same time and putting too much torsion out, that could cause a problem. And the thing was still stuck, right, but it does. So my next setup, I was super careful, very specific, and I was trying to move that one segment. And when I did that, there was no spasm, there was resolution of the low back pain, and everything felt great. Okay, so I had to kind of learn my lesson, of course, on the hard way. They did too. Thankfully, they were really forgiving about it. I would have known that at the time. But now you do. Okay, so again, you really want, that's the difference between chiropractic versus something like a physical therapy, mobilization, is that one is like adjusting just everything and hoping for the best. The other one's applying a specific force to a segment that truly is subluxated and doesn't move. That's the difference between them. Now, the inside of the joint itself is lined with something known as the synovium, but the outer portion of the joint is surrounded by this articular capsule. So outside of the joint is a strong supporting articular capsule. Inside the lining of that articular capsule is where we find the synovial membrane, and the synovial membrane is what produces the actual synovial fluid itself. So again, when you have a joint, are the two bones touching each other? No, we don't want them. If they do, that's going to cause a lot of pain and discomfort. Instead, there should be that synovial fluid between them, lubricating the joint, facilitating the mobility. Surrounding the joint will be the articular capsule, and on the inside of that articular capsule will be the synovial membrane that creates the synovial fluid. And then outside of that articular capsule, which does provide some support and stability, there'll also be ligaments that hold the bones together beyond that. They're providing more stability and support. Now, there's 6 types of these synovial joints. You got to know them all. You got to know the classification. You got to know where you would find these out as well too. This is just a typical synovial joint. Here we can see the synovial membrane. Here's where the synovial fluid would be. There's the articular or hyoid cartilage on each end of the bone. And this is the elbow joint. What kind of motion does this do? Flexion, extension. It looks a little bit like a door opening and closing, right? So we call this a hinge joint. So it falls under one of the 6 classifications of synovial joints. It's a hinge joint. Gliding joints are also known as planar joints. Can you think of somewhere where you have planar joints, flat surfaces, right on top of each other? Where, well, the wrist definitely. And in the spine, you remember those facet joints? The superior and inferior articular facets, they're nice and flat. Those are planar type joints, also known as gliding type joints. Okay, and they make a nice smooth motion. So like 2 pieces of glass separated by some smooth fluid that allows it to move. Yes, sir?
I have a question regarding this fluid similar to like cerebral spinal fluid.
No, because the purpose is different. So the synovial fluid is intraluminal. The cerebral spinal fluid outside of good question, though. Again, gliding joints. This is a good example where you can find this in the hand. If you take your carpal bones, and believe it or not, your carpal bones are like here. They're not like down here in your hand, they're like here. These are our carpal bones. If you put your fingers on either side of those carpal bones, you technically can move them around a little bit. Okay? You should be able to. If you can't, that might mean that they're stuck or subluxated. Stuck and subluxated don't mean the same thing. If something's stuck, that doesn't necessarily mean it's subluxated. We'll get into the classification of what makes something truly subluxated versus just something that's stuck. Doesn't mean you might not want to free it up. It just means that it's just not necessarily a subluxation. So again, as you put your fingers here, you should be able to move those bones a little bit. You feel that movement in your fingertips? Those are those gliding type joints, or planar type joints. But again, we find them in the vertebral column, and chiropractic definitely should know that. The condyloid type joints. Condyloid type joints are a little different because of their surfaces. Normally what happens is that you have one end that kind of looks nice and rounded, sort of like the occipital condyles. If you look at the base of the occiput, you see these nice circular occipital condyles that kind of hang down. And then they fit into the superior articular process of C1. So C1 almost looks like a cup or a bowl. And then the occipital condyles just fit nice and snug inside of it. Okay? So again, a condyloid type joint typically has an irregular shape to it, but normally it's sort of circular or like a semicircle, and it fits into something that looks almost like a fossa, like a deep surface. Okay, we'll see an example of that in camp. Yeah, like that mandibular fossa as well, where the mandible actually fits into the skull. That's a mandibular fossa technically, but it's like a condyloid type joint. Yeah. So if we look here, we can see an example of a gliding joint. You see these flat surfaces in between each other? Each one of those would have a gliding type joint. The condyloid joint, you see how this proximal, or excuse me, the metacarpal or the distal metacarpal here connecting into the proximal phalange. This one has this nice rounded edge here. And I know it doesn't look super deep, but if you take this bone and you separate it, it actually has like an indentation in the bone itself that receives that metacarpal. Okay? We good with that? So again, a condyloid type joint, we can find them there, metacarpals, metacarpal phalangeal joint. We can also find the gliding joints here. And a saddle joint, and we want to remember a saddle joint because the saddle joint specifically, we normally think of it here at the carpal, metacarpal joint of the thumb. Okay? So carpal, metacarpal, what does that mean? These are the metacarpals in your hand. These long bones that you can feel right through here, these are the metacarpals. These are your phalanges. Okay? So when we say metacarpal, we're talking about this, right? This one in through here, it's talking about the carpo-metacarpal joint, so carpal, metacarpal joint. So it essentially is this joint that articulates right here with the bone known as the trapezium. So where the trapezium articulates with the first metacarpal, which we see right through here, that specific joint itself, that's a good example of the saddle joint. Now sometimes I'll ask you questions about the carpal joints, and that's where a carpal bone is articulating with another carpal bone, and those are gliding joints. If I ask you about this joint of the thumb, we know we're talking about a saddle joint. Saddle joints are a little bit like a horse sitting in a saddle. It allows for typically flexion, extension, a little bit of lateral motion, but it does so with more stability because there's something kind of blocking it in place. Does that make sense? So it still allows for a range of motion similar to what we've seen previously, but it does so with more stability, so there's less chance of dislocation or fracture. Hinge joint, we already mentioned that, right? Can you think of another hinge joint in your body? Your knee. Your knee is sort of an atypical type hinge joint because it's kind of complicated. It's not purely flexion and extension. There's also some gliding that's happening as well between the distal femur and the proximal tibia, so there's some gliding that's happening in there. And your hinge joint at the knee, there's also some internal and then some external rotation that's happening as well too. So it is still classified as a hinge joint. It's kind of an atypical because there's the associated glide of the knee, because you can actually move your tibia slightly anterior and posterior. And then there's also internal and external rotation of your tibia as well too. So it's a more complicated talk. When we fully extend our knee, we internally rotate the tibia and it locks in place. Okay? When we flex our knee, it externally rotates to bend. If your knee's not doing that, it's not properly moving through that range of motion, and that could be a big problem for maybe a track athlete or maybe just somebody who's working at Walmart, standing on their feet all day long, uncomfortable because they can't actually move like they're supposed to. So again, when you get to your upper and lower extremity adjustment class, you guys will learn how to adjust that. It's really easy to do, no big deal. Ball and socket joint, where are the ball and socket joints?
Hip.
Glenohumeral joint and the femoral acetabular joint. So we said hip, that's the generic name for it, and sometimes we'll refer to it just as the hip joint, but the technical name would be the femoral acetabular joint. It fits into this thing known as the acetabular fossa. I remember it because it's close to where your ass is. So, I know it's vulgar, I know it's bad, okay, but just stick with us a little bit better. So where the femoral head fits is known as the acetabular fossa. It's right here, it's kind of close to your butt. So that's how I remember it. Or that's how I used to remember it. Now it's just generic. Pivot joints, and you guys see the Friends episode, they're trying to get the sofa up the stairs, and they're like, pivot, and it doesn't work. A good pivot joint, or at least what I think of as a good pivot joint, is between the atlas and the axis. The atlas is the first bone in your neck. The axis is the second bone in your neck. So between the atlas and the axis, right here, there's a pivot joint. Now that pivot joint is primarily responsible for our no motion. Okay? It's really hard to say yes when you're shaking your head no. I like to mess with my kids. They'll come up and they'll ask me for something, and I'll be like, yes. And they're really confused. They don't know which one I mean. And then they yell at me too. So I can't tell if you're serious. I don't know what you're doing. That's great. The angle that's essentially created through there is what makes the pivot itself. itself. So this little thing that looks like a finger sticking through here is known as the odontoid process, and it sits right against the anterior arch of atlas, and it's that sitting on one that makes the other. So it pivots along the odontoid process where it bends. Another place where we see a pivot joint is between the ulna and the radial head. The radial head has this nice circular shape that fits inside the ulna and creates that motion. Now, the ball and socket joint of the hip may or may not have a lot of range of motion, depending on who we're looking at, but it has the capacity for a lot of range of motion. But typically, it has lots and lots of stability. One reason it has more stability than our glenohumeral joint is the depth of that fossa. You see this big depression right through here? It's a pretty sizable fossa, and the floral head kind of sinks into it. Now remember, it's not touching it, so it's not completely connected in there, but it's deep inside there. So the depth of that fossa is what creates some of the stability, and then there's bigger, stronger ligaments that hold that together as well, too. Yes, sir?
You said it's not connected and it just touches, but isn't there a ligament in there?
There is, called there's a ligament from the foveus impalis, there's a little ligament buried in there. That ligament itself, it's connected in there, but the actual bony tissue itself, it's not directly connected. Yeah, yeah. Yeah, it's like a suction. It's almost like a suction type effect. If you've ever seen like a relocation, typically once the doctor gets the joint back in the appropriate position, the body almost suctions it back into it. Part of that is achieved by the muscular tissue that's supporting the ligamentous tissue, but also that synovial fluid almost creates like a suction type force that wants to keep it inside the joint. And we see the same thing in the glenohumeral joint. It's not to the same depth though, because the fossa is really shallow. The glenoid fossa that sits inside is really shallow. Now, there's things that we do to enhance that by creating what's known as a labrum. A labrum is sort of a soft tissue structure that sits around the root of it and deepens that fossa. We have the same thing in our hip as our shoulder, but again, the hip joint or the thoracic vertebral joint is a lot deeper. Yes, ma'am? Yeah, so if bone is rubbing on bone, it can be so painful that somebody might want to kill themselves, which is not moving at all. It's literally just sitting there to so much pain. But it depends on like what's causing it. You know what I mean? If it's severe degenerative joint disease and there's no way turning back, then maybe that's a good candidate for hip replacement. If a patient develops something called avascular necrosis, we mentioned a minute ago that ligament that helps hold the head of the femur in place. Inside there is an artery that goes to the head of the femur. And in situations where people are long-term smokers or have severe cardiovascular disease, it can compromise your arteries. You may not think about that, but when you have long-term cardiovascular disease, it affects your arteries. If that blood supply gets cut off to the femoral head, you no longer have blood supply going to the head of that bone. Will that bone live without that blood supply? No, it develops what we call avascular necrosis. A means without, vascular meaning blood, necrosis, tissue death. If someone experiences avascular necrosis of that femoral head, it will eventually collapse, and then they'll need a hip replacement surgery. And that hip replacement surgery is pretty graphic too. It's pretty intense too. They're in that layer of work with a 9-inch sledgehammer to get this big dagger dug into the bone and start to screw it in. Yes, sir? I don't know what the association is with that. Listen, we'll ask like when we get to our radiologist, Dr. Dupois, Dr. Gallen, Dr. Fox, and say what the association is with that and osteoarthritis. But for some reason, there does tend to be some sort of an association with osteoarthritis and people being able to tell. So I don't know exactly what the sign is. Just the pressure difference. Yeah, I haven't seen any papers specifically on that, but we'll look at it. Maybe we'll look at it.
You mentioned dislocations and what was the
Huh?
chiropractors address dislocations?
That's a great question. So whether or not you can address dislocation depends on two things. Number one could be the state you're in, and whether or not you have any postgraduate certification. So if you get postgraduate certifications either as a CCSP, which is a certified chiropractic sports practitioner, or CCED, which is a certified chiropractic discriminating practitioner, they're similar certifications. Those allow you to do relocation. But you don't have to, but you are able to do that. But generally, like in the state of Georgia, you can't do that. So if someone came in with a dislocated shoulder, dislocated arm, you can't relocate that, even though the procedure itself is important, or at least normally. When I was in Haiti doing the shows, I saw two people that dislocated shoulders. One person that got hit and then the other person, she had been in a motorcycle accident with maybe down like 10 years before, and the mom was ready to be coming in here. And so we could relocate the shoulder, but there was no muscular tissue to hold it because it had all acted. And so it would just fall right back out of the joint. Just sort of been out of the for so long. I guess it's possible that we do it and it stay well, and then maybe we can get this one there. Sure. Well, it depends on which bone we're talking about. So in between like the tibia and the talus itself, it's typically sort of like a nice smooth joint, but it also has that kind of little surface on it. And so that's typically where we see like dorsiflexion and plantar flexion, conversion that's happening in the joint itself. But there's also other bones in the foot that are similar to what we have in here, so like carpal bones, and those are more like bony joints. And then also there's where the metacarpal is dislocated. And so it was a big toe and the vertical knee. So it sort of has, so it's sort of like the hand that has like a multiple toes and has a little bit more part of the callus fitting on the tibia. So each one of these categories of a synovial joint, all synovial joints are classified as, starts with a D, diarthroidal. So all diarthroidic joints are synovial joints. The 6 categories of synovial joints have in all. Okay, we have our planar joint, landing joint, Underwood joints. We have our saddle joint, hinge joint, and then you have your ball and socket, your pivot joint. There's only 6 of them. Okay? If you try to commit yourself to learn those, maybe do over just the next week, you'll have them now. Okay? But you have to review them every once in a while because again, you won't take that NBCE test until like 6 or 6 quarters. Okay, so it's like over a year away before you actually take that test. So you got to make sure that you review it. If you do, I mean, again, that's a good 50% of the test is going to be right. Okay, and that's a large portion of that test, especially if you're going to do questions for the range. Okay, let's talk about specifically the cranial. Let's get maybe 20 more minutes and we'll be done. We'll be done by 8:30, but no break. You handle that? If you need to, remember, stand up, move around, just don't fall. So you can stand up, move around, stretch a little bit, just don't fall. All right, let's talk about the cranium. The cranium is divided into 2 parts. The neurocranium is what's protecting your brain. The viscerocranium is what's protecting your face. It's formed from similar tissue, but not exactly the same tissue. The neurocranium is formed by something known as the mesenchyme neural crest cells. When we talk about neural crest cells, we're going back to embryology, and we're talking about the different tissues that differentiate or change into the different tissue types. So you want to know that the neurocranium comes from neural crest cells. That's pretty easy, neurocranium, neural crest cells. Okay. The viscerocranium, though, comes from our pharyngeal arches. So these are these small arches that you see as the head begins to develop around the neck area. We'll see these different arches that are developing embryologically. Some of these cranial bones are part of both the neurocranium and the viscerocranium. Our cranium versus our skull, the skull contains the mandible, the cranium doesn't. It's really the only difference between the two. So if we're talking about the skull, we're talking about everything, whole shebang, including the jaw. Okay. If you're talking about just the cranium, you're really just talking about the neurocranium and the viscerocranium. Neurocranium, viscerocranium. Again, the only difference is that there's a few bones that overlap kind of here in the middle. Okay, and we'll see some of those grouped into both of those. I like to remember the neurocranium is just protecting my brain, you know, the neurology. The viscerocranium is just protecting your face. The neurocranium itself consists of 8 different bones. You have to know what they all are. There's 4 singular bones, which is the frontal, ethmoid, occipital, and the sphenoid bone. There's 2 paired bones, the parietal and the temporal bones. If you were to maybe put on a little circular hat on top of the head, you ever seen the ones that have like a little pinwheel on the top of it? You put that on, and then you cut someone's skull off right along that line. We're cutting off the clavarium. That's what we do if we're doing a dissection, like a gross anatomy dissection. We might cut off the clavarium so that we can get inside the cranial fossa. Most of our skull models, you can attach to the clavarium and see inside the cranial fossa and then underneath it. Now, the clavarium is made from the frontal bone, temporal, and the occipital bone. So the frontal, the temporal, and then the occipital bone, and we cut just around. It's just a small portion of the occipital bone. The floor, or the cranial base, is made up of our sphenoid, temporal, and a portion of our ethmoidal bone. And we'll see each one of these in just a second if you're not familiar. Hopefully you've got maybe the week 2 or 3 doing your lab project, and so you've seen some of these bones in the lab. I can appreciate it's difficult to visualize these if you haven't seen it before. Pneumatize. What does pneumatic mean? Like air, right? Yeah, so contained air pressure. A pneumatized bone contains air space. So essentially we call that a sinus. Okay? Another way of saying it is just a pneumatic bone. The pneumatic bone just has space inside of it where we have some air. And typically that's going to reduce the weight of that bone. So again, we think of them as sinuses. We find these in the frontal, ethmoidal, temporal, specifically at the mastoid, and then the sphenoid and ethmoid bone. And overall, these do decrease the weight of the actual bone itself. Here we can see the bones of the neurocranium. Again, we want to know what those bones are. We want to know what the neurocranium is. We want to know what the covarium is. We want to know the difference between the skull and the cranium. Okay? That's basic kind of anatomy stuff. You need to know. The cranial base, I like to think of in colors and just seeing it here. But you need to know which bones are making up the different parts of the cranial base. And there's some overlap between some of these bones. Okay, so I do really like the picture, but the picture only helps you if you know the names of all the bones inside the cranial fossa. Okay, so again, those are all listed for you right here. And we need to know which bones are in the anterior, middle, posterior portion. And I would pay attention to anything that's connected between the two. So like the sphenoid bone, we see as part of the anterior and as part of the posterior as well too. So again, I would go through this. I'm not just going to read all this list to you, but again, I would go through and I would make sure I can identify each one of those. Hopefully that lab project is helping you guys do that. Now the viscerocranium, again, that's our facial bones. Okay, the viscerocranium is our money maker, right? Facial bones is our money maker, maybe not. Okay. I like faces that have a little bit of asymmetry. Yeah, it's like faces that have this touch of asymmetry. So there's just something that's just a little off. I feel like it gives you character. It makes you look unique and different. I like those the best. You see anybody who's like perfectly balanced, like their eyes are perfectly spread apart at the same exact height. The right nostril is exactly as the left nostril. Okay. Huh? I don't know who that is. But we should look at pictures. When we get to gross one, we will. I have pictures and we'll look at pictures. Send that one to me.
You've never seen the Barbie movie?
I have. I don't know who he is. Who is he?
He's the main character of Barbie.
Oh, it's her. I didn't know it was a girl. Yeah. Yeah, I did. I watched the Barbie movie with my kids. Yes, I did. Felt sort of bad for Ken. Wasn't that bad? Like Ken Rebellion there? I mean, that kind of overdue. They should have done that a long time ago, right? Yeah, put Barbie in, at least in that world, right? Facial symmetry is pretty rare, right? When someone has complete facial symmetry, it almost kind of like ticks something in your skull, and you're like, well, wait a minute, is that person pretty? Are they not pretty? What's happening here? So you can have facial symmetry, but that doesn't necessarily indicate beauty to people, right? Like I said, when I see people with just a little asymmetry, I think of that as being really beautiful. When I see people who are perfectly balanced, I'm almost like, oh, that's weird. And that's throwing me off. I don't think I can talk to you. But it's probably because my face is so asymmetrical. I got an eyebrow that goes up here. The nose is just a little off over here. Okay. The bones that make up the face itself, we have our frontal, nasal, lacrimal. Here they're all listed here. I'm not just going to read them all to you. There's lots of openings that we're going to find inside the viscerocranium, and that makes sense because that's how the blood supply is going to pass through those bones to get to some of the deeper tissue. Supplying things like the inside of our nose, our oral cavity, orbital cavity. Some of these bones between the viscera and neurocranium, they articulate with each other, forming things like the zygomatic arch, the orbit, where we find the eye, or the nasal cavity. Okay, here are all of our viscerocranial bones. And outside of an osteology test or an MBCE test, will you ever call this the viscerocranium? Probably not. That's one of the reasons why it can be really hard to remember. But it's such a simple question, right? Like, what are the structures of the viscerocranium? You have them and try to help yourself learn those and memorize those. Viscerocranium. Inside the nasal cavity, there's a lot of different bones inside there, partly composed of the viscerocranium and the neurocranium. We need to know what these bones are. And what we've done here is we've taken the skull, we've cut it in half, like right down the middle, and we're looking inside the nasal cavity. Now, depending on where you cut, you may see this wall separating out the left and right nasal cavity. This is known as a septum. If you were to imagine us taking this big room right through here and we wanted to make it into 2 rooms, and we put just a wall right down the middle, the wall right down the middle would be the septum. Does that make sense? We then would have a right, and then we'd have a left room, so to speak, or we'd have right and left. The same thing happens in the nasal cavity. To divide off the left and right nasal cavity, there's a septum that divides out those 2 different openings. Now, the bone is kind of complicated because it's not made of just one bone. It's made of our ethmoid bone, specifically the perpendicular plate of the ethmoid bone. If you don't know what that is yet, you'll see that when you get maybe to the week 4 structure list in your lab projects. But it's all part of this bone right through here, which is known as the ethmoid bone, and it has multiple parts. The one portion we see through there is the perpendicular plate of the ethmoid bone. Inferiorly is a singular bone known as the vomer. Okay? The vomer is the inferior portion that kind of makes up the inferior part of this nasal septum. Anteriorly, we can see that it's made primarily of the septal cartilage. Now, when we're looking at the skulls, we won't see the septal cartilage because it's been removed so that we only see the bony tissue. So again, you're not looking at those when you're looking at the actual skulls because that's been removed so that you can see the actual bony tissues. Now, if that's the septum, it's got to be sitting on top of the floor. Does that make sense? What's the floor that that's sitting on top of? This is our maxillary bone. And at the posterior aspect, we see something known as the palatine bone. Okay? So the palatine bone and the maxillary bone join together to create our hard palate. So the roof of your mouth, the hard portion, is made primarily of the maxillary bone. The posterior portion is made out of the palatine bone. And that creates the floor of the nasal cavity. Now, if we go in and we knock down this wall, and we look at the lateral parts of the nasal cavity, like over here, this part, we're going to see these little folds of bone in there, known as the concha. They're just broken up into the superior, the middle, and the inferior nasal concha. The superior and the middle are both associated with the ethmoid bone. So far with the ethmoid bone, we've seen the perpendicular plate and that the superior and middle nasal concha are both associated with it. And that's on the lateral wall of the nasal cavity. Okay? Septum is right here. The inferior part right through here, the inferior nasal concha, is an individual bone that's separate. You typically will see it attached to the maxillary bone, but it's technically a separate bone altogether inside of there. But it normally doesn't get any attention whatsoever. It was a while before I even realized it was an independent bone, not actually part of the maxillary bone. We okay with what makes up the nasal septum? You could get a question that asks something like which of the following bones makes up the superior portion of the nasal septum, and then you'd be expected to say either ethmoid bone or perpendicular plate of the ethmoid bone, which would be the most specific answer in that situation. Yes, sir? Okay, I think I'm back. When we're taking multiple choice tests, we got to keep in mind that sometimes there'll be 2 right answers. Okay, and we need to pick the right answer. Okay, that sounds wrong, right? Right. But remember, if we're taking a test and it says which of the following bones makes up the superior aspect or the superior portion of the nasal septum, and we see ethmoid, and then beside it we see perpendicular plate of the ethmoid. The perpendicular plate is the most specific part of the ethmoid that makes up that wall. Does that make sense? If perpendicular plate of the ethmoid is not present, then we just go with ethmoid here. Does that make sense? But the perpendicular plate of the ethmoid is there. It's the most specific. And so technically, ethmoid and perpendicular plate of the ethmoid, they're both right. But technically, the perpendicular plate is the most right. And unfortunately, your NBCE test will ask you lots of questions like that, which means I have to ask you questions like that too. Okay? So again, be prepared to answer questions when you ask the question. I'm not intentionally trying to be mean and up on you. I'm just trying to prepare you for what you got coming. Here we can see the nasal septum without the septal cartilage associated with it, sitting on top of the maxillary bone and the palatine bone. And we want to make sure we're aware of what makes up those. In the orbit, we can see that there's lots of bones that make up the orbit. Of course, the orbit's where our eye is sitting. The orbit itself is made up of our frontal bone, our sphenoid bone. We've got part of our zygomatic bone here, our maxillary bone. We've got our lacrimal bone. You can see the ethmoid right through there. And then there's just this tiny little sliver, that little bitty part right there of the palatine bone. When you think of the Palatine bone, you should think of it as sort of like a field goal, okay? It's kind of a large bone that's like this, okay? This little bitty piece down here, this makes up part of the palate, but it continues going way up until it actually connects into the orbit itself, leaving just that tiny little piece. Okay, so the the Palatine bone can't be seen from the orbit of the eye. And sometimes you'll get questions like that, like which of the following bones contributes to the orbit of the eye? And the Palatine bone will be looked at and you're like, I don't think that goes there. It's a palate. It says in the name palate. So don't get tricked, don't get confused by little stuff like that. Now, we're going to see that each one of these bones have lots and lots of landmarks. Okay? As you get into the week 3 and week 4 structure portions of your lab project, you can see these bones have lots and lots of landmarks. Essentially, 3 weeks out of the material is dedicated to learning all these lumps and bumps and holes and slits in the actual painting itself. Okay? So again, we do want to make sure we're aware of the different openings we see through there. When you see an opening in a bone, what does that tell you? Something's going through there. There's typically not just free space inside of a bone unless there's some sort of intention or some sort of purpose through there. Our optic canal that we see right through here, this is where our optic nerve passes. Optic nerve connects to the back of your eye, so on the cranial nerve tube. Our second cranial nerve, it's the optic nerve that passes through the optic canal. To the superior orbital fissure, the majority of our other structures get into the eye, which are the blood vessels, meaning arteries and veins. Other neurological tissue passes through the superior orbital fissure as well. Okay? So again, each time you see one of those openings, in this class you don't need to know all the stuff that passes through there. Okay? But as you get into gross 1, you will be looking at all the structures that are passing through there. If you understand at least the openings, then it's like you just learn the stuff that passes through. Okay? So we definitely want to make sure we know those different portions. The cranial buttress system is really one reason why we have that in there, and that's just to understand essentially how forces are dissipated on the face or the cranial bones. Have you ever fallen or gotten hit in the face? I've been punched in the face a number of times. It doesn't feel like I used to do karate, but we used to fight all the time. So I got punched a lot. The very first time I went to a karate school, the black belt who was there that I was sparring with, he saw off, nailed me right in my nose. I thought he broke it. I thought it was like detached and hanging off my body or something. That's how bad it hurt. And he nailed me right through there. And it was like, 5 years of that. Okay? So again, we can take a pretty good strike to the face without maybe going breaking. So my nose didn't break that day. And really, I had a cut over my eye, but that's the most I've ever had when it came to my face. Just a small feature, just took care of it. But the rest of my facial bones were fine. And why was that? It's because of the cranial buttress system. Essentially, the cranial buttress system of your face or your skull exists to dissipate forces so that if you do take a hit, maybe to the face, along these structural lines, that force will sort of be dissipated or spread out. Does that make sense? It's sort of like something hitting the water. The point of major impact is obviously going to leave like a big splash, but then there's these ripples. The ripples are sort of like that force being dissipated through the actual face itself. So when we look at it, there's these system or buttress system in place where these forces are actually displaced so that the bones don't fracture. Now you can overcome that system, okay? So if you got hit hard enough with a baseball bat in the face, anybody ever been hit in the face with a baseball bat? I have. Who did it? Did you do it? Oh, no. And somebody swung you. Oh, no. Did you get a concussion? No? Oh, that's intense. Me and my friends were playing a game called basketball. It was going really well. Like when the ball was like here, it was going pretty well. The ball was like sailing, and then they threw the ball right at my face. And so of course, I didn't get out of the way. I just did this. Ball came right back and nailed me right in the face. I mean, my eyes swelled up like somebody's business. Okay. Now, thankfully, my bones they didn't fracture. I guess I just have a thick skull. But they didn't fracture that time. But those are the types of injuries that typically will overcome the cranial buttress system and actually cause someone to experience something like a fracture. So what do we need to know about this buttress system? We need to understand the basic structures that are essentially supporting these different, dissipation forces we see passing through the lines. So we know where they're at. Really, if you know the names of the bones, they're pretty straightforward. Like, you know the zygomatic bone, the maxillary bone, you can envision where that's happening. You can see it, like where it's happening, the zygomatic maxillary bone. if you know the names of the bones, these actually become very simple for you to learn and understand. The primary thing that we want to understand, though, is that this cranial buttress system is protective in nature. It helps to dissipate forces, and it's one of the reasons why we don't do a lot of fractures when we do take strikes. So boxers don't normally fracture their skull bones. What happens to boxers and fighters? CTE. Yeah, because what's happening to the brain every time you get hit? This is one of the things, like when I was in the karate program, I wouldn't say that I wouldn't get hit. I was trying to learn self-defense. And so my goal was always not to get hit. But a lot of people love it. A lot of people, they love it. And so those people who are getting hit all the time, their brain is just bouncing around in there. We get these things called encounter tooth injuries, where the brain is actually bouncing around like a peanut inside of a shell. And unfortunately, that begins to do systemic damage over time. That's why a fighter can be like the best fighter you've ever seen in your life, and 5 years later, they can beat anybody. Okay, and depending on the quality of the fighter and their ability to sort of deflect those punches, the longer they can stay in the game. So you've seen people who learn how to slip punches and things like that. That's them essentially taking less of impact when they get hit, so they can stay in the fight longer. Yes, ma'am? So there are associations between that degradation in neural tissue. So Parkinson's disease is typically thought of as being related to the buildup of these amyloid proteins inside of our brain. And unfortunately, I don't know if there's a direct correlation, meaning that getting hit in the head directly relates to that. But I do know that getting hit in the head advances neural degradation, which I would say would lead up to the buildup of those plaques potentially, and could lead to that. So is it a direct correlation? I would say that no, it's probably something in the pathway that's destroying neural tissue itself links to those types of things. Parkinson's disease has a lot of components that are contributing to it. We found associations from the vagus nerve, which connects to our gut. And so there's some connections between maybe what we're eating and our gut biome as to whether or not we develop things like Parkinson's disease. So it's kind of a complicated conversation of like what causes this and what causes that, and those types of nerve situations. We okay with the idea and the concept of this cranial buttress system is there to protect us, essentially. The articulations of the cranial bones, we're almost done. Okay, for today. Probably pick up here next week. Articulation of the cranial bones. When we first developed and we're passing through the birth canal, our cranial bones are actually very fluid and movable because they're not fully developed yet. Most of it is cartilaginous, and so as babies going through the birth canal, the skull will actually collapse in on itself and then pass through the birth canal. Now, that doesn't really change the fact that it's still this head popping through the birth canal. Anybody here witness a birth? Yeah, that's ain't very good, man. Like, I remember the first time that I was there and I saw like this head coming through. I was like, oh, that's kind of cute. The head was kind of small, and then the head popped out, and I was like, I almost like lost it. I was like, oh my gosh, what just happened? This head, this alien, is like popped right out. The head was huge. I was like, my God, what happened? As baby's going through the birth canal, that skull is collapsing, but as it comes out, it's all going to sort of swell back up. Okay, baby, when they're first born, sometimes if they've been in the birth canal for a little while, the head shape may be a little strange or looking a little odd. And you'll see over the next 24 to 48 hours that will start to go to what we would consider normal. So sometimes, you're proud, the baby's born, you get there and take a picture, and then you're like, like his head like rebalances. It looks so much human. I love you. You're beautiful. You're beautiful. So beautiful. So we're going to stop there for today. One thing I want to remind you of is do not let that osteo